Patient's haemoglobin's dropped, do we transfuse them? Another patient, respiratory distress, and then the neurosurgeons phoned up, we've got this patient that I told you about, we need to intubate, we've done the CT, what we're going to do. So those were all the decisions, and what I did was I sort of stood back from that and I tried to say what are the categories of decisions that we have to make. So there are housekeeping decisions, there's the things about, we're going to give this patient some potassium, we're going to give them fluids, what we're going to do in terms of their feeding. There are decisions which are about safety, and sometimes the safety stuff is to do things urgently. This patient needs intubated and ventilated now, or to do things in a delayed manner. We need more information before we go ahead. It's talking to a colleague who'd been along doing some training on ultrasound with one of the radiologists on Tuesday, and radiologists going, respiratory guys have asked us to do an ultrasound on this patient's chest. I mean, clearly it's a pleural effusion, they should just stick a needle in it. Sticks the ultrasound on, no fluid, just consolidation. So if they just stuck a needle in it, you're in a bad situation. So sometimes you have to delay your decision making, and in our context 25% of our patients don't survive, so a lot of that is to do with end of life care. Then there are these professional decisions, things to do with maintaining your service and keeping things going, but also to do with the fact that people have personal issues at work. I've highlighted support and treatment differently because in your areas, I know that we're talking about folk from primary care and out in the community, right to our advanced critical care practitioners and advanced practitioners in a very acute setting. But you should tease out the difference between support and treatment, because we can take somebody in to the ICU and put them on a ventilator and a filter and give them vasoactive drugs, but if there isn't an underlying treatable, reversible disease process, there isn't any use for that. So it's balancing the support and treatment thing, and that's about making a diagnosis. Distributed decision making, my example of that is the registrar got a phone call from Stirling, as it was, and accepted a patient. The SHO went to a cardiac arrest and accepted that patient, and I got a phone call from elsewhere and accepted the patient. We only had one bed. It was a quick trip to IKEA to get... there's a woman called Janine Rogalski who has done quite a lot of work on distributed decision making in a very interesting context, and that is Mediterranean firefighters. So you've got 6,500 people out there trying to fight this fire, and some of them are pushing it that way and some of them are pushing it that way, and how do you make sure that they don't either injure each other or make things worse. And I'm not going to go into joint decision-making, collaborative decision-making. We've had quite a lot of discussion about this as our advanced critical care practitioners have gone through their prescribing, and about the fact that if you've got somebody on a ventilator, it's very difficult to join up the decision-making with them. You can't talk to the staff looking after them and the family. I think I've covered all of those already. Okay, so those are the kind of clinical decisions that I get involved with, that we get involved with as we walk around the place that we work. I'd like to see if I can get some of you awake. So we're going to have a couple of things that you need to do. So anybody an ornithologist? Could say, is anybody a tweeter? But okay, what's this bird? Robin, thank you. What's this bird? Robin. There's a pattern emerging. What's this bird? Anybody remember Mary Poppins? The film? Helen Singh, did you shake your head there? Right, that'll be our next CPD day. That is a robin. That's an American robin. And if you remember, the film Mary Poppins was set in London, but it was made in Hollywood, so the bird singing on the tree outside when she sings A Spoonful of Sugar was an American robin, because it says in the book a robin was singing on the tree outside. So they've got the diagnosis wrong. That's a European robin. Who said this was a robin? Should have gone to Specsavers. Anybody know what that is? Some kind of finch. That's a Siberian ruby throat. And if you read Bill Oddie's stuff on bird watching, it's the sort of thing that he travels thousands of miles to see. So you all used a very quick form of thinking to either not make a decision or to make a decision as to what those birds were. That's just to warm you up. That's all right. Okay, which beach would you like to be on? That's right. That's left. Pete was talking about doors being on the right and left. He was facing that way and you're facing that way, so I've no idea where you... I think dinner's through and lunch is through there. So do you want to be on the right or the left-hand beach? Hands up for the right. And the left? Good, there's always one. If you've seen the original and the remake of the Thomas Crown Affair, it may well be, if you're an international art thief, you want to be in Shanghai on that beach because it's much easier to hide than it is. So I showed this. We'll discuss your criminal record afterwards if that's all right. I showed this to about 120 people at the College of Physicians, and they had these voting things. So as we go through these three bits, I'll show you how they voted. So the vast majority of them wanted to be on the beach in Hawaii, just like you did. Very nice. I can give you the email address of Fiona, who's got the cottages just next to the beach. Talking a lot about holidays here. Okay, so what's the diagnosis? I'm going to give you 5 choices. Psoriasis, pityriasis rosea. I like saying that, that's why I put that in. Can't remember what it is. Shingles. Hands up, who thinks it's shingles? Pemphigus. I wasn't very good at dermatology. And Sutton's syndrome. So this is how the folk in the College of Physicians voted, and C is shingles. It's dermatomal in distribution, vesicular, it doesn't cross the midline, and there's nothing else that looks like that isn't shingles. The problem with the answers is the 5th one, because Sutton's syndrome doesn't exist. I made that up. So somebody's voted for something that doesn't exist. Or it may exist in a parallel dimension. My children make me watch Doctor Who. So. How difficult was it for you to make that decision, that diagnosis? You've seen it before, it just pops up. Okay, so nasty rash, which was generalised, very sick patient. Hands up, who thinks it was pneumococcal septicemia? Cryoglobulinemia? Meningococcal septicemia? Okay, good. Majority there. Microscopic polyarteritis. Not to be mixed up with polyarteritis nodosa. Staphylococcus aureus septicemia. course, we're not allowed to have that anymore. The government have said. I think I remember what HEAT stands for. So what did they vote? So the majority went for meningococcal septicemia, but there's a bit of a spread here. Any idea why? Is that a diagnostic clinical feature? The reason I chose those 5 is that I've seen patients with that rash with every single one of those. My thinking is that the respiratory physician saw pneumococcal septicemia, the rheumatologist who sees infected joints saw Staph aureus septicemia, the nephrologist microscopic polyarteritis, because that presents with that kind of rash and acute renal failure, and the haematologist sees patients with cryoglobulinemia. So we used exactly the same thought process, rapid fire thinking process, but we might not have been right.